All right, so we're doing ABGs, and after this we'll be doing end-tidal CO2. So we'll be taking the CO2 component of ABGs, kind of thinking about it and what would happen on the outside once we exhale the CO2 from our bloodstream, right? So ABGs, you may know the acronym ROAM. That I got you through nursing school, pretty strong, but we're gonna go, it still is applicable, but we're gonna talk about some of the causes and how to fix them, okay? And then also how to fix them on the ventilator, right? So on the ventilator, we can adjust different values, right? So we can fix the CO2 and we can hopefully fix the bicarb by adjusting the CO2. Okay, so ROAM being respiratory opposite. So if your pH is going up, that means your CO2 is going down. So CO2 at 30 means that they're blowing off CO2, which is an acid, right? So blowing off a lot of acid, pH goes up. That's just how science works with pH. Okay, metabolic equal. So if you have a bicarb that is low, that means the bicarb has been utilized with neutralizing different acids, okay, different acids that will kill you. And that's our acronym for different acids that might build up in the body, and that will then drop your pH, right? So ABGs, we'll talk about some normals and how you compensate and how to interpret it towards the end here. Okay, and ABGs also are one of the most painfully reported things in the ICU. So ABGs are intermittent, all right? Usually they get done daily, so with someone on the ventilator, but sometimes it'll be every 12 hours, even someone every 4 hours if they're super sick. And we mentioned the other day that, you know, if you have like red numbers on your labs, right, we should probably get another ABG to follow up in 2 to 4 hours to make sure that the numbers are going in the right direction. All right, so when they first get intubated, they are get intubated for a reason. And sometimes you get an ABG to validate that. Say, oh shoot, the pH is really, really low. We should intubate them, right? It depends on the situation, the clinical picture. But we want to get ABGs after intubation to check our work, and then also look to see if there's anything else we need to adjust after the fact. All right, so normal values. So on a arterial blood gas, it is in this order. And I swear sometimes it changes on me. It's like sometimes they sneak the PO2 up below the pH, but usually the pH is always first. All right, so pH 735 to 45, you just drop that down 35 to 45, and that's your PaCO2. All right, and we said CO2 is an acid or a base? It's an acid, right? It's technically carbonic acid, right? So carbonic acid is made from CO2. So when you have CO2 and water, when they get together in the bloodstream, you give them enough time, right? 5 minutes, they start getting together, they hook up, and they start making what's called carbonic acid, right? And carbonic acid will then dissolve in the bloodstream as hydrogen ions, which is an acid, right? And bicarb. The definition of an acid is something that dissolves in water and makes hydrogen ions. That's just a chemistry definition, right? When you put something in water and it starts making hydrogen ions, that something is an acid, right? So CO2, you put it in water, you give enough time, it will make an acid, right? So that can be beneficial because at the tissues, you're making a whole bunch of CO2, right? And we said it takes time, right? So it's going to take time for it to make that, turn that CO2 into acid. And why would you want to do that? So CO2 itself, the gas, it's very difficult for that to travel in the bloodstream, right? It's going to take a second for it to dissolve, right? If you ever opened a soda, right, the CO2 is always it wants to come out, right? But if we dissolve it, right, you mix it and mix it and mix it, then it may turn into an ion, right, with a charge on it, a little positive charge right there. That's going to make it attached to water molecules. Water molecules are bipolar. They have a little positive charge at the top, a little negative charge at the bottom. So it's easy for things to attach to it and then travel through the bloodstream, right? So it's a mechanism, a protective mechanism to move things around, okay? So CO2, we want to move around. We would take it from the tissues and then drop it off at the lungs. And it's a very, very quick process. So the carbonic anhydrase enzyme right here, that's what's utilized to make the CO2 in water, and eventually with enough time it will make hydrogen and bicarb, but the carbonic anhydrase makes that equation happen like at 40 times the normal speed. So it's like really, really quick. Let's go ahead and make a whole bunch of hydrogen and bicarb so we can shuttle it through the water, because we know later we can get rid of it at the lungs, if the lungs are working, right? So that's the anticipation of what will happen. Okay, so CO2 and water form together to make a carbonic acid by the effect of this enzyme right here, carbonic anhydrase. Okay, and then that hydrogen and bicarb will then, they will then go the other direction once they're at the lungs, and then form themselves in a CO2 and water. okay, at the lungs, and then now the CO2 will go to work from high to low, just like everything else in the universe. Everything's high to low. CO2 will go from the pulmonary capillaries into the alveolus, and then we'll exhale it. Okay, and if we're making a whole bunch of CO2 of the tissues, which can happen, like in hyperthyroid, or they have like a neuromuscular, like a neuroleptic malignant syndrome or malignant hyperthermia, something where we're making a whole bunch of CO2, you can actually, that's gonna increase the CO2 in our bloodstream, and then we can then expel that, and we can detect that on the end-tidal CO2. Okay, but we can do ABGs, and when we see the CO2 is high, we're thinking, why is the CO2 high? 9 times out of 10, the CO2 is high for what reason? Yeah, they're not blowing it out, right? If you're delivering all this stuff to the lungs, right, all the CO2 to the lungs, and the lungs are breathing really, really slow, right, per minute, you're breathing 4 breaths, breathing 4 breaths per minute, that's just 4 breaths of getting CO2 out. If you breathe 40 breaths per minute, you're breathing a lot of CO2 out in that minute, right? So that's what we are looking for. We're looking for getting rid of CO2 or not getting rid of CO2. What is the patient doing, right? And they'll be doing that based on different situations. If they need to get, sometimes they'll do that, the lungs will compensate, right? Say, hey, CO2 is an acid, and I'm building up acids over here. Let's go ahead and get rid of the CO2 really quick at the lungs, right? It's like second place to one of our ways to compensate really, really quickly, right? The first place is our cells. Our cells will switch real quick and try to fix an acidosis. But our lungs are second place to try to blow off CO2 if we get building up acids, okay? So the lungs excrete CO2, okay? You can maybe pee out a little bit CO2, but it's not significant. All right, and then PaO2. So we spent a whole lecture last lecture about PaO2 and PVO2 and SpO2 and SaO2 and all the O2s. So you're probably O2 tired, right? O2'd out. But O2 is important, right? And we need to establish that it should be how much? It should be 80 to 100, right? And if it's more than 100, is that okay? No. So that's hyperoxia, and hyperoxia leads to more damage to our tissues. So we want to keep it 80 to 100, and 80 to 100 usually without oxygen. So with oxygen, we're providing oxygen to a patient, and we want to maintain. We know that it correlates to their stats. We want their, what's an acceptable PO2 for an ICU patient or even a patient in the hospital?
SpO2?
PO2. PaO2.
Oh, anything above 60.
So PO2 is 60. That's cool, right? Remember the 4, 5, 6, 7, 8, 9 rules? So 4, 5, 6, 6 being our PO2 is 60 is equal to 7, 8, 9, 90% sats, right? So 88 to 92% sats are perfect for any patient except for a little asterisk on which patients would you like to have a little bit higher?
Like MI patients.
MI patients or stroke patients, right? MI or CVA patients will accept a higher sat. And how high? So 80 to 92 is everybody except for these guys, which is what, 92 to 95, right? That's what ideal, right? If you're more than 95% in on oxygen, you take the oxygen off, right? Does that mean you extubate them? No. You just do the lowest vent settings that we can provide for oxygenation, okay? So then that's our oxygenation, right? And oxygenation is a function of, we can measure it on our ABG with PaO2, and we can associate it with our O2 saturation. And of course, that's our O2 hemoglobin dissociation curve. That doesn't look like that. It's like this, right? Like that, right? So that's our O2 hemoglobin dissociation curve that we are, familiar with. That, based on changes in pH, changes in temperature, we will drop off more oxygen to maintain our tissue oxygenation. So looking at PO2 can tell us, we know that our tissues will take about 0.3% of the PO2, and it will then utilize that. If PO2 starts getting lower and lower and lower, it can be a reflection of O2 saturation, of course, but also a reflection of tissue oxygenation. So we want to make sure that's maintained at least above 60 in the hospital setting, but 80 to 100 is perfect. Okay, so hypoxemia, we spent a whole hour, 2 hours talking about that last time, okay, and VQs and shunts and such and dead spaces. So when we have impaired ventilation or impaired perfusion to pick up the O2 from the lungs, that's going to lead to a drop in our sats and a drop in our PaO2, right? So that's what we're thinking about when we see a low PaO2. We're thinking, why is that happening, right? What's going on? Are we unable to pick up the O2 because my right ventricle has failed, or I have a huge PE? Or is it because I have a huge pneumonia or ARDS? Is that reason why my bloodstream is not picking up O2? right? And we can measure that with what? Or we can we can use a roundabout number to say, oh yeah, the amount of FiO2 I'm delivering and the PO2 I have on the other side, that PO2, that should be much higher, right? Because I'm delivering 100% oxygen, I should be able to get really, really great PO2s. And a healthy person, 100% oxygen makes your PO2 like 500, right? But and a person with ARDS or a person with really bad pneumonia, really bad CHF with pulmonary edema, that's going to cause that to drop, right? And what's that little equation we look at? It's called the PO2 to what?
The gradient.
Yeah, the AA gradient if you're fancy, or if you're not fancy and you're a cowboy, you say the PF ratio, right? So PO2 divided by FiO2, or PF ratio, right? Literally, you take the PO2 of 60, divide by the FiO2 in percentage, so if it's 50%, 0.5, all right, 60 divided by 0.5 is 120, right? So that would be a good or bad PF ratio, 120. That's bad, right? Less than 150 is ARDS until proven otherwise, right? And to prove it otherwise, you've got to look at the X-ray, and we look at some other things, okay? So that's just a recap on PO2 from last time. And we got bicarb. So bicarb is an acid or base. It's a base, right? So more base means it's going to scoop up and it's going to bind to what? What's a little negative thing? It's going to bind to hydrogens, right? Bind to H pluses, right? So more bicarb, H plus disappears, right? And H plus is an acid. So this base is going to be regulated by the kidneys, and the kidneys actually hold on to more bicarb when there's more acid around, right? It will A, get rid of acid, and it will also B, hold on to more bicarb. And our kidneys are as fast as the lungs or slower than the lungs? Very, very slow. About 18 hours at best. Usually, next day, that's when they're going to start kicking in and start holding on to more bicarb and making sure that we're getting rid of acids in the kidneys. Okay, so 22, 26 is normal for bicarb. When you look at like true north, what is the absolute perfect ABG? That's right here, 7.40, CO2 of 40, and bicarb of 24. And then 24 plus or minus 2, that's our range, right? So that's 22, 26. Some books say 28, that doesn't gel, right? That's not even. And it doesn't check an OCD box, right? That's 20. It's 24 plus or minus 2. It's not 24 minus 2 plus 4, right? So it's 22 plus or minus 2. Our perfect CO2, right? Perfect PA CO2 is 40 plus or minus 5, so it's 35 to 45. Perfect pH, 740 plus or minus 0.05, right? So that's 735 to 745. 35 to 45, and 22 to 26. That is what we're looking at when we look at our normals, right? Because sometimes when you're interpreting ABGs, they're 738. So that's technically the acidotic side of pH, right? Because 740 is perfect. If it's 740, you can't interpret an ABG. You can't say, oh yeah, that's metabolic. Ooh, what is that? Is it acidosis or alkalosis? Is it metabolic normal? What is that, right? So it has to be 739 or 741, and then we can say if it's alkalosis or acidosis, right? Which one is alkalosis, 739 or 741?
Alkalosis.
So 7.41 would be your alkalosis, right? And then SATs we talked about a lot last time, right? And this SaO2 is technically your arterial saturation that we grab from our ABG, right? Our ABG will spit out an SaO2, which is more accurate than the SpO2. What's PO2 stand for? That's our P stands for pulse ox. Yeah, you can say peripheral, but it's your pulse ox, right? So your pulse ox is just comparing empirical data from post-World War II vets, right, after lunch. So it's just saying, and white guys too. It wasn't white women, it wasn't black men, it was white guys, right? And they assessed that was, this is SpO2 for the next 85 years, and that's what it was, all right? So SpO2 is a pulse ox, but if you want to look at true SAT, that'd be your SaO2, okay? Right? Any slight deviation from these will be acidosis or alkalosis, so we can kind of see what side it is, right? Because 24 going down to 23, going down to 21, going down to 19 on our bicarb is meaning we're going in what direction? Are we getting acidotic or alkalotic? You're getting acidotic because bicarb is neutralizing acids that might be building up, right? So the bicarb is being utilized. It's going from 24 to 21 to 18 to 15 to down to 5, right? Another reason why your bicarb might be dropping is you're pooping it out, right? So you could be losing bicarb, or your cells are hiding the bicarb because you gave them another negative ion, All right, that happens too. We like to bolus patients with sodium chloride all the time, normal saline. It's really abnormal saline because it actually, when you give sodium chloride to an acidotic patient, all the chloride goes in the bloodstream. And it's like, what am I doing with all this chloride? Well, let's go ahead and make room for this negative ion and push the bicarb into the cells. And now the bicarb is in the cells. Does this measure the cellular arterial content or the arterial, right? So all that bicarb hid away, right? So we'll talk about that when a little more in kidneys, but we'll touch on it here. That's called, when you talk about anion gaps, right? You have anion gaps that are high, are high or low, right? But you can have metabolic acidosis with both. Okay. So what might bicarb be neutralizing? These are acids that will kill you, right? When you look at some resources, they'll use this mud piles acronym, but it has like super rare stuff that you don't really see, right? Methanol ingestion. I mean, how many people are ingesting methanol, right? How many people are taking isoniazid, right? Not too many, right? Aspirin, yeah, maybe. Iron poisoning, not too many, right? Ethylene glycol ingestion, they're drinking antifreeze. Okay, yeah, so sometimes, but these are not a common occurrence. But the common things are things that will kill you. We'll explain the acronym on the next page, right? So that's just ketones, ingestions, such as ingestions of ethylene glycol or methanol, L for lactate, and U for uremia, because we're going into kidney failure, right? So we have that explained on the next slide, I believe. Okay, so these are things that will raise your anion gap, which we'll touch on more. Okay, and there are things that will drop your gap, that will make it so that, because you have metabolic acidosis, but you are pooping out all the bicarb. The reason why you have metabolic acidosis is not because of acids like lactic acid or renal failure. It's because you're losing bicarb, right? And the bicarb is there to maintain this balance. It's a literal scale. You have bicarb on one side, and you have hydrogen ions on the other side. If I lose the bicarb, I'm going to get more hydrogen ions and therefore more acidosis, right? So that's the idea behind our ABG numbers, right? So bicarb is our acid base. That's literally our scale right there, right? And of course, CO2 is going to be involved to also affect our pH, right? So when CO2 builds up, what does that do to my pH? So the pH is going to go down because CO2 is an acid. What kind of acid? What specific acid is it? Carbonic acid, right? So carbonic acid builds up with more CO2, and then it needs to be ventilated. It needs to be, the only way we get rid of CO2 is expelling it, right? We can maybe hold on to bicarb the next day, or we could maybe, give some other things to maybe neutralize, but really the best way to get rid of CO2 is to let it come to the lungs and then ventilate it out, right? And we can make them ventilate faster with mechanical ventilation, right? We can change settings on the ventilator. We can increase what things to make that happen.
Respiratory rate.
Respiratory rate is a good one. That's one we know about, right? And go for respiratory rate of 14 to 20. That's going to make them breathe more CO2 out of their lungs, right? If you're breathing 14 times a minute, that's going to be compared to 20. You're going to blow out a lot more CO2 out of your lungs, because that's what they do when you're breathing 20 times a minute. I'm not sure what's happening up there. All right, it's a little ketamine infusion you just got. All right, but anyways, you have a respiratory rate, but you also have tidal volume, right? So tidal volume, if I'm breathing 10 times, let's use our previous example, 14, and my tidal volume is 100 cc's versus a tidal volume of 1,000 cc's, right? If I'm doing 100 cc's of CO2 10 times a minute versus 1,000 cc's 10 times a minute, right? That's going to be a lot more CO2, right? So those are the two things that get rid of CO2, right? Is the volume of CO2 I'm exhaling and the rate at which I'm getting CO2 out. The rate is our respiratory rate, and the volume is our tidal volume, right? And we can multiply those together, and we get a cardiac output of the lungs. How much volume of air am I getting out per minute, right? And that is my minute ventilation. Okay, so minute ventilation in a minute. How much ventilation are you doing? That's well, A, how fast you're breathing, and also B, how much volume with each breath is that? That's with each tide, with each inhalation and exhalation. All right, so we have ABGs. We also have VBGs. VBGs are venous blood gases. There are other normals to it. Okay, so we look at our normals for VBGs. They're off by a little bit, because if you remember back to our big ventilation diagram last time, we had, our lungs are going to pick up O2. Sorry, they're going to drop off O2. They're going to pick up CO2 from the venous circulation and drop off O2 onto that venous circulation to make it oxygenated and therefore arterial, right? So you expect the CO2 to be higher on the venous side or lower?
It's going to be lower. Or
No, higher, right? Because they just came from the tissues, and the tissues dropped off CO2. That's what tissues do. They take glucose, lipids, or proteins, and they take oxygen also, and they're going to then spit out heat, but they're also going to spit out ATP, which we want. They're also going to spit out water, and they're going to spit out CO2, right? So the CO2 that gets spit out is going to then be formed into carbonic acid. It's going to make its way all the way to the lungs, and now we have more CO2 on the venous side, right, when we do a VBG. So the CO2 is going to be off by about 6 points, right? So you just add 6 to our normal values, right? And that's going to be an assessment of how much CO2 someone's retaining, right? If they're retaining a lot of CO2, we can do a VBG and say, oh shoot, that's more than expected. The little caveat is too much CO2, right, or in severe shock and too much CO2, it's not as accurate. But our pH is usually a good target, all right? So we expect the pH to be lower or higher on our VBG. Be more acidic just because of the CO2, right? Our CO2 is contributing to the acidosis because there's more carbonic acid circulating because that's what our tissues do normally, right? Bicarb maybe might be able to use, but it's not as accurate as an ABG. Definitely what's not accurate is your PO2, right? PO2 is not a reason you're getting a VBG. So PO2, the only reason I kind of bring it up here is because PO2 is going to be less than 40, right? And we kind of demonstrated that on the slide before. But PO2 is not going to, when your PO2 is less than 40, when they do an ABG, you're like, well, shoot, was it venous, right? Because it might have been venous. And you can look at your CO2, and you can see the CO2 is a little bit higher. So that's a way to kind of associate it as an ABG versus a VBG. All right, so this is a quick diagram, kind of a summary of what we talked about before last time. When we said your CO2 is going to be leaving, going from 46 to 40, right? Because it just picked this up from the tissues, right? The tissues here were producing CO2, and that's what made our number go from a normal 40 up by 6 points, right? Yes?
And when you say is it venous, would that be like user error or like?
It could be user error, yeah. So a VBG could be user error from the ABG, right? They got a venous radial, right? But also times we do it on purpose. We'll just get it from a central line, or we'll get a venous VBG because it is less painful. So because we just want to know what the pH is, like in a DKA patient. Do we really need an ABG? Sometimes all you need is the VBG to see if the pH is like super low. The pH is 722. It's like that's not severe DKA. Okay. So yeah, so pH, CO2, bicarb, and PO2 are all there. Just the numbers look a little bit funky. You just got to figure out what we're looking on the venous side. We expect them to be a little more acidotic. Okay, ignore this part here. This is not really that useful, but there is a quick way to there is a change when you change your pH and when an acute state versus a chronic state, they do compensate differently. All right, but again, VBGs become inaccurate when you have severe hypoxia, severe acidosis, like in a severe shock state. This is a more stable patient. You just want to do a spot check to see what their pH is or their CO2 is. But when the CO2 is like ridiculously high and like they're like on the floor and they gave them Narcan, and you're like, well, that CO2 will not be as accurate as an ABG. So an ABG is usually still our go-to. Okay, so yeah, so pros ABG, it's exact. Or cons, it's very, very painful. There could be delays. You have to get a specialist down there. You have to get the respiratory therapist. They're like hunting for their artery, which is the size. If you look at how big an artery is, it's super, super small, right? So it takes a lot of skill to get an ABG. All right, so VBG, usually we can hit. Usually we have a central line or PICC line we can grab it out of, okay? And there is good correlation with our pH that we mentioned, right? And CO2 has good correlation until you start getting CO2s or start climbing more than 45 to 50, okay? What else? So what is the venous oxygen saturation, right? So that's going to be, it's usually around 60 to 80%, right? So, and then that's going to start falling and falling and falling as we get more and more acidotic, and also when we get more tissue use of oxygen. that can drop, right? So we can get an oxygen saturation. Oxygen saturation is different than the SVO2, right? There's SVO2 and there's different than a PVO2. So PVO2 is how much oxygen did the tissues take up, whereas how much O2 saturation is my hemoglobin. Because remember, hemoglobin are 100% saturated at the lungs. They go to the tissues and drop off just one little O2 molecule, and they become 75% sat. Right, so you could get a saturation as well off this. All right, so pH, the power of hydrogen. All right, so pH will tell you if you are acidotic or if you are alkalotic, right? So pH, what's a perfect pH? 7.40. All right, so 7.40 is a perfect pH, and for just 1.01 points down, right, 7.39, we are now on the what side? Acidotic or alkalotic? Acidotic. So here's perfect right here, 7.40, and as we start getting down here, we start getting acidotic, right? We start getting alkalotic when we go 7.41 and above, right? And usually, 7.50 is usually not compatible, sorry, like 7.60, sorry, is usually incompatible with life, right? 7.8, yeah, definitely not going to be surviving after that. That is not a good sign, right? Less than 6.8, you've probably seen some impressive pHs, like 6.76 maybe. Those are usually not compatible as well, okay? So yeah, so pH, you got acidosis, you got alkalosis, and what made them acidotic? Well, it's going to be a drop in our bicarb or a rise in what? Drop in bicarb or a rise in CO2. And that's going to tell us why they're acidotic. So if their CO2 starts rising and rising and rising, we can say that was a respiratory reason, right? And just a quick tip, anything CO2 causing a change in pH, that is respiratory, right? When we're establishing what kind of ABG it is, it's either, if it's the CO2 caused the problem, it's a respiratory problem. It's either respiratory acidosis or respiratory alkalosis. So if our pH is acidotic, less than what? What number? Less than 7.40. And the CO2 made that happen. That means the CO2 was greater than what?
45.
Technically 40, but yeah, greater than 45 because 35 to 45 is normal. So CO2 is greater than 45 and my pH is less than 7.35. Yes, that is a respiratory acidosis. Why did that happen? Why did my CO2 go up? What's a good reason for that? Yeah, decreased minute ventilation or decreased respiratory rate or decreased tidal volume, right? One of those two things, right? Someone's breathing 24 breaths a minute, but they're breathing 150 mLs, right? That means they're tired, right? They were before breathing really fast, 400 cc's, 600 cc's, and then all of a sudden they're breathing still 30 breaths per minute, but it's only 150 cc's. They're tiring out. They're not getting rid of enough CO2, right? So the buildup of carbonic acid, CO2, due to hypoventilation, right? That's decreased tidal volumes or decreased respiratory rate, is going to be a reason for a respiratory acidosis, right? Why do we say it's respiratory, not metabolic? Because what caused the problem? CO2 caused the problem. If it was, we would say metabolic acidosis when the pH is low, right? And also when the bicarb is low or high. Bicarb is low, right? Because bicarb neutralizes acids, right? So if bicarb is neutralizing acids, is bicarb going up? No, it's being used up. So bicarb is going down from 24, perfect, to 22, not so perfect, right? To 20, 18, 16, all the way down to less than 5, right? So why would bicarb go down? So it's binding to acids that are being produced by the body, right? Some of these acids are protective, like lactate. It's a protective acid, right? When it starts getting more than 2, it's not protective anymore because now it's like increased debt, right? Lactate is literally the tissue's debit card, right? Or I should say credit card because anyways, because once you run out of money on your debit card, you're not going to get any credit, right? So it's a little credit card, right? So once it's more than 2, right? Once it's twice as much as your paycheck, then that's you're like, well, shoot, now I'm in debt, right? They literally call it an O2 debt. Right, so lactate is more than 2, then now that's going to start causing acidosis and start causing problems. Right, so lactate builds up when? I don't have O2 in my mitochondria. Mitochondria shut down when there's no O2 delivery, right? So my mitochondria are shutting down because of hypoxia, right? My tissues are getting hypoxia. Why would they get hypoxic? Well, it's based on how much DO2 they're getting, right? So DO2 is the delivery of oxygen. Right? What was the components of DO2 again? cardiac output, right? So tissues don't care about, you just got to give me oxygen. I don't care what's going to happen, right? Just like when you order a package on Amazon. I don't care you ran out of gas. My package is not here, right? I'm going to go into lactic acidosis if I don't speak to your manager right now, right? So it's the delivery of the driver, right? There might be traffic on the 14, like all the traffic that's happening, like it closes down. So yeah, so there's the inadequate flow to my tissues, or they don't have enough space in their van, and they couldn't get my package right now, right? So there's not enough O2 being delivered. So one of those two reasons, hypoxia or poor perfusion. So low BP or hypoxia. When you have sepsis or severe infection, right, septicemia, that's what causes, that actually independently disrupts our mitochondria. Mitochondria just shut down because of the inflammatory response. Okay, so that's another important reason, and that's why in sepsis, septic shock, severe sepsis, that whole continuum, they're all about the lactate, right? What's the lactate? The patient has sepsis, what's the lactate, right? Because sepsis directly interferes with the mitochondria, and therefore they're going to start producing lactate, right? The cells will produce lactate. So lactate's an important reason why, when that builds up, important acid that when it builds up, it's an acid, right? And that's going to do what to my pH? Going to bring it down, and who's going to try to fix it? That's the bicarb. The bicarb is going to try to neutralize it and try to, hopefully maintain my pH balance. And why is it so important to maintain the pH balance? Because it's going to start causing death, right? So that's what we'll talk about this next little bit right here. Okay, so going back to other acids your body produces, your body will produce acids when you are starving, right? When you are starving, you go into ketosis, right? Or you don't have insulin, right? Insulin is a hormone that's protective that will store away your sugars and such, right? When you don't have insulin, your body thinks you're starving, okay? So yeah, so you have ketones that build up, right? Keto acids, there's 3 of them. There's 3 ketones. 2 of the 3 are keto acids, right? So we have 3 ketones. They're protective. The brain loves them. They'll eat them all right up. But as soon as they start building up and building up and building up, they are 2 of the 3 of those ketones are acids, and therefore it's going to cause acidosis. And therefore my bicarb is going to try to neutralize them, right? There's beta-hydroxybutyric acid, which is one we can measure on the labs, right? So every DK patient that comes in, you're going to see a BHB be ordered, right? A beta-hydroxybutyric acid, or BHB, okay? If that's high, and you do an ABG and their pH is low, it's like, well, the reason why they're in DK is because, or the reason why I know they're DK is because the BHB is there. That's what's causing it, right? But as we know with DKA, usually what prompts it is A, they didn't take their insulin, or B, they have a really bad infection, right? There's some other reasons like MIs and CVAs, right? But anyways, most commonly they have an infection brewing, right? So usually we do a lactate as well, right? We want to make sure we're covering all our bases. All right, so those hydrogen ions build up because of acids, right? So what else could cause, yes?
Sorry, so then is it the gap that's we use to determine whether it's closed down?
So yeah, so we'll talk about anion gap briefly. We'll talk a lot more about anion gap in renal, but yeah, we have a little section on anion gap. So anion gap is it's a measure of what anions are not present. It's like looking about what's left, right? So we add up all the ions and cations that are in the body, right? So anion's bicarb, right? So bicarb is usually neutralizing things. So either the bicarb's dropping or my hydrogen ions are building. There's no blood test for hydrogen ions. You say, oh, I'm going to look at my hydrogen ion count, right? You have to measure it indirectly by looking at what is being gained or lost. So we'll look at that briefly, okay? All right, so ingestions, you can ingest things like aspirin, you can ingest, which is acetylsalicylic acid, right? So ASA, acetylsalicylic acid, is if you take too much of it, you're going to start dropping your pH and your bicarb will go down, right? And if you take in polyethylene glycol or ethylene glycol is go lightly. So we just take off the poly and make it ethylene glycol, which is antifreeze. So that's when you give go lightly to your patient. This is just one step away from antifreeze. That'll make them drink it, besides the flavor and the amount, right? Anyway, so yeah, so they have ingestions can cause you to get acidotic, and then also we have renal failure, right? Your kidneys get rid of toxins and they get rid of acids for one, but also in renal failure they get rid of potassium, right? So if we can't get rid of potassium, as we'll learn, that potassium, when it builds up, that's not good. So your body says, you know what, the potassium is building up, let's push in the cells in exchange for what? Because your body knows when your potassium gets really, really high, it's going to start to affect which organ? The heart. Someone's pointing the heart, right? So your heart's going to start getting affected. So your body knows that. It's like, you know what? I'm going to do you a favor. I'm going to take this potassium, I'm going to put it in the cells so we can still have a heart rate and I can still live. And then we're going to exchange it for what? So our cells take the K, they put it inside the cells, and inside the cells they expel, because it's a positive charge, they expel something else positive. Cal hydrogen, yes. So hydrogen, all right. So hydrogen is going to be exchanged, right? So hyperkalemia leads to acidosis, right? So yeah, so when you have renal failure, you can't get rid of potassium, therefore you get acidotic, right? And also you can't get rid of hydrogen ions either, and when you have renal failure. So that's going to build up and build up. Because remember, our kidneys, they're also protective and they can get rid of hydrogen ions too, okay? So those are the reasons why your pH would drop, and get acidotic, because you're losing, your bicarb is being used up, right? It's used up binding to these acids that will kill you, okay? The other reason why your bicarb might be dropping is because you're losing it, right? And why are you losing it? It's not using, you're losing it. So you're losing the bicarb because you did what? You have diarrhea, right? Bicarb is produced by what GI organ?
Or the small intestines.
So inferior to the stomach is the organ that's retroperitoneal to the intestines, called the pancreas, right? So your pancreas produces bicarb and it spits it into the duodenum, right? Which is just below your stomach, just distal to your stomach, right? So if you're squirting bicarb into your small intestine and you have diarrhea, right? That's going to leave your body before you can reabsorb it, because you reabsorb your bicarb in your jejunum or your ileum at the end, right? As you squirt bicarb to neutralize all those gastric contents, you're going to reabsorb it, right? At a certain rate, right? Like an I Love Lucy rate, right? So you're going to take the bicarb, put it back in. You know what I'm talking about? You guys watch I Love Lucy still, right? So yes, you have to take the bicarb from your intestines, you put it back in your bloodstream, and then it's going to be recaptured in your pancreas. But if you have diarrhea, it's going way too fast, right? They don't have time to take it out, take it back, right? So if you have diarrhea, you're losing bicarb. And now, remember our scale, if you lose bicarb, the hydrogen ions are going to, or not the hydrogen ions, but the pH is going to go which direction? If I lose my bicarb. Yeah, pH is going to go down. Okay, so I'm going to have a loss of bicarb, or the bicarb is being hidden because someone gave sodium chloride. That'd be another reason why that would happen as well. So we'll talk about that. All right, and then I'll switching gears to alkalosis. All right, alkalosis is a pH greater than what? 740 technically, but yes, 745 is definitely we're on the alkalotic side. And why are we alkalotic? It's either due to a respiratory cause or a metabolic cause. And respiratory always means that what value is changing. And what caused the problem was CO2, right? So CO2 is going up or down in alkalosis?
Down.
CO2 is going down, right? So CO2 is going down. I'm blowing off CO2. CO2 I know is carbonic acid. It's an acid. So if I'm blowing off too much CO2, that's going to make my pH go what direction? Go up, right? So pH starts going up, which is alkalosis. Okay, so that happens because of hyperventilation. Any change in tidal volume or change in respiratory rate, right? That is too high or too low?
Too high.
So too high of a tidal volume or too high of respiratory rate. And these two numbers are numbers on the ventilator, right? You can adjust, it can be adjusted. Usually we want a doctor's order before we change respiratory and tidal volume, right? But those two numbers can be changed to affect the ABG, right? If someone were super alkalotic, it's like, well, shoot, let's come down on tidal volume a little bit, or let's come down on the rate a little bit. All right, and then metabolic alkalosis. It's due to a change in what number and what value. What value is causing the pH to go up? It's our bicarb, right? So our bicarb is going up. And why is the bicarb going up? Well, usually you don't see too many high bicarbs in ICU. And when you do, it's really one of two or three things, that reason why that's happening. So the families give them too many Tums, right? So way too many Tums. You slow back, pump the brakes of the Tums, right? Because Tums is sodium bicarb, right? So someone gave too much sodium bicarb, your stomach's just going to absorb it, and now your bicarb level is going up. That's not very common, right? What is more common is that you're taking the bicarb, you're taking away hydrogen ions from the stomach, right? So when you have diarrhea, your bicarb is being lost. But when you have taking hydrochloric acid, which gets produced in the stomach, and it's coming out, right? Because your body will reuse hydrochloric acid too, right? And to keep balance. So you're losing too much hydrochloric acid out of your stomach, right? Then that's going to cause a metabolic alkalosis, right? So a GI cause of affecting our ABGs. All right, and then we have bicarb gain. So we're gaining too much bicarb, again, by Tums, but also it's due to potassium wasting diuretics. This can also do it. All right, so we'll talk about this briefly when we talk about the renal compensation of bicarb. But when you lose, if hyperkalemia leads to acidosis, hypokalemia leads to alkalosis. Those two things are true statements and facts that happen, right? When we're getting way too alkalotic, your body's gonna say, well, I know how to fix that. All I'm gonna do, you're alkalotic, you need to have a good pH to operate things. So I'm gonna put some K back, I'm gonna put some K into my cells and take some hydrogen ions from my cells and put it into the bloodstream to try to neutralize this, right? It's a cellular way to balance our pH, right? So to balance our pH, we have three ways to fix it, right? We can use our lungs to either blow off CO2 or not blow off too much, right? Or we can use our cells to move potassium around, to move hydrogen ions in or out. Or we have a third way, which is our kidneys, which are the slowest way. Okay, so why is pH such a big deal? Why is it so narrow, 735 to 745? It's because every enzyme and protein in the body ever needs to operate at this level, right? It needs to operate at between 7.35 and 745. If it's outside that range, your cells cannot work, right? Because your cells need proteins and enzymes to work, right? So it's needed for that, otherwise they literally melt, right? So when you have a pH that's abnormal, you're literally melting the cell's proteins, right? And the cool thing about them is that they can, once they melt, and go right back to normal shape as long as you correct the pH, right? If you don't correct the pH, they keep melting, cellular processes break down, and then eventually, if it's a heart protein, right? You have your sodium ion channels, you have your potassium, calcium ion channels that maintain electrical gradient across the heart, and your heart stops, right? So your pH is too low, your heart can stop. Also, when your pH is too low, your K is going to start to be affected as well, right? So enzymes, again, are proteins, right? Cell respiration enzymes, everybody's favorite. You can no longer make ATP. ATP is important for every cellular process, right? You can't make proteins. What are proteins for? There's enzymes are make proteins, right? And these enzymes are used to either build proteins with anabolism, right? You're making new RNA and DNA. You're making new, endocrine hormones and such. So now you can't make them, right? You can't do these processes that are normal, right? Your myosin actin sheaths in the cells, they get denatured and you get weak with low pH or high pH too. Okay, and then other important proteins, hemoglobin. It can't do its job. It gets denatured. It can't carry oxygen that well, right? Usually, you'll make 2,3 DPG to kind of get rid of oxygen as much as possible, but eventually that process is going to break down. You cannot make that protein 2,3 DPG, right? So then you can't deliver oxygen to your tissues, right? And then you have protein carriers and protein channels, like we mentioned in the heart, right? So you start getting arrhythmias. In your CNS, you can't do protein channels to carry, you have GABA channels, you have norepinephrine channels, you have serotonin channels, you have all these different things that are opening and closing. These are proteins, they get denatured, and things can't pass through the brain normally, so they get altered, right? So you have altered. You can even get to the point where they can't keep calcium out of the neuron, right? And calcium is like a frat boy. Once calcium is let loose and gets into the cells, it's going to start turning everything on and start getting seizure activity, right? And then we have the kidneys, right? We can't control our electrolytes. Liver, you can't make proteins such as all of our clotting factors, right? 1 through 13, but not was it 11, 9 or no? I think there's no 1 through 14, but there's no 13, right? They don't make clotting factor 13 for some reason. Anyways, you can't make your clotting factors, right? Endocrine can't do their endocrine thing. So all these things processes start shutting down, right? And we talked about the muscle fibers don't work as well. So pH is important for this reason. That's why it's important to recognize and get the pH within 735 to 745, right? Besides pH, temperature is also something that makes everything operate normally, right? So when your temperature is too high or too low, it's not going to work, right? Your proteins don't work. And you want your white blood cells to work. And your white blood cells, they can take a little bit of abuse with more heat, but who can't? bacteria. So your body protectively makes you febrile, so to literally melt the bacteria, right? And your white blood cells will then get to work and hopefully get them under control. All right, so CO2. So CO2 is going to affect our ABG, all right? It's going to affect our pH. We mentioned that CO2 gets produced at the tissues, right? And we want to take that to the lungs, right? We take it to the lungs, and we're going to make and drop it off there. But CO2 does not dissolve easily in the serum, right? So we can then hitch a ride as just bicarb, right? We can convert it into hydrogen ion and bicarb. All the numbers add up, right? So carbonic acid, just there's 2 H's, there's 3 O's, and there's 1 C. All the numbers, we just kind of rearrange things, make it have a charge, and charged things dissolve great in water, right? Water is what our serum is mostly made of, right? So just like glucose, right? Glucose dissolves into water easily because glucose has a charge and water has a slight charge. Whereas fats, oils don't dissolve in water because fats don't have a charge, right? So they separate out, right? Unless you use like a ninja, and then you can emulsify and make mayonnaise. Anyways, but you can't do that, and you don't see your cell. What's going on? Oh, I'm really acidotic right now, right? So it's not gonna happen. So in the meantime, we have to then convert it into something that can be transported, right? And we do that in the serum. So the serum does this. So here's our cells producing all the CO2 over here. It makes its way in the interstitial fluid, goes across into the arterial capillaries, or the capillaries technically aren't arterial or venous, but the capillaries are in between the arteries and veins, right? And then we're going to dissolve it in the serum, but also our RBCs are going to carry this carbonic anhydrase enzyme, and they're going to turn it into bicarbonate hydrogen ions, so they can be transported quickly up to the lungs, right? Up to 60% of our CO2 is transported on our RBC, right, on our hemoglobin molecule, and in our RBC. But whereas like 97% is transported in our O2 is transported in hemoglobin, 60% is transported right outside the hemoglobin in the RBC, and another 30% is actually bound to the hemoglobin molecule. It makes room for it. Okay, so we have carbonic acid. We've got our carboxyhemoglobin, and then we have our CO2 that's just dissolved, right? So our CO2 just dissolved in the bloodstream, and that takes a second to dissolve, and this is what we pick up on our ABG, right? It's a measure. It's the smallest measure, just like when we do a PO2 on our ABG. It's really the smallest part, right? Less than 3%. But it's 80 to 100 that tells us an idea of what's going on elsewhere. Same thing when we look at our CO2. It tells a story of what's going on. All right, we can't stick a needle in the RBC to assess it, right? So that's how CO2 is transported in the plasma. It's transported just straight up dissolved, right? That's less than 10%. And then we have the CO2 that gets formed by carbonic anhydrase into hydrogen bicarb, so it can be easily dissolved A, in the RBC, or B, in the plasma itself. Okay, so we have to bring that over to the lungs, right? And when you're at the lungs, it's going to then go the opposite direction, right? At the lungs, it takes this hydrogen bicarb and it turns it back into CO2 and water. Okay, and the CO2 will then dissolve out of the cells, dissolve from the bloodstream into the alveolus, and then it will then be exhaled, right? And as long as you're exhaling great, your CO2 is not going to build up, right? It's at a certain rate, a rate of 12 to 20 breaths per minute with a normal tidal volume of 500, 800 cc's, your CO2 will always be maintained, right? But what if your respiratory rate drops and your tidal volume drops? What happens to your CO2 levels? They're going to start rising. They're going to start rising more than 45, and that's going to start to make me acidotic or alkalotic. Acidotic, which is a low pH, right? So respiratory rate times tidal volume is your minute ventilation, right? So any change in one of those two things will affect my carbon dioxide level, right? So those are the things that we can affect and we can change, right? So on the ventilator, we can change the respiratory rate or tidal volume to fix someone's elevated or low CO2. When would you increase the respiratory rate and tidal volume on the ventilator? The CO2 is too high. And we have other things we can do before the ventilator, right? We have BiPAP therapy, we have vapotherm, high fluid nasal cannula therapy we can do, or we can just tell them to do what? Should be a little bit faster. All right, so we'll finish this slide. We'll take a quick break. But serum CO2, if you can't get an ABG, you have a poor man's ABG, because everybody gets a chemistry panel, a basic metabolic panel, or a comprehensive metabolic panel if you're fancy, right? If you can wear a top hat, then you can maybe get a CMP all the time. But a basic metabolic panel has usually about 8 things on it, and one of those 8 things is a CO2. But is that CO2 my actual CO2 from the ABG? No, it's not, right? It's actually the bicarb, come to find out, right? So serum CO2 is not your CO2 that's dissolved in the bloodstream, right? Like when we do an ABG, we stick a needle, whether it be VBG or ABG, we take a sample and we are actually measuring the CO2 molecules. When it goes down to the lab, they're not doing that, right? All they're doing in the lab is adding a reagent to the blood and seeing what number comes out, right? And that number that comes out is the bicarb, right? Because of carbonic anhydrase. We know that in the serum in the previous slide, the CO2 and water get together and they form hydrogen ions and bicarb, right? So remember we just said 60% is in the cell itself as CO2 and water, 30% of our as carbonic acid, and then we have 30% actually bound to the hemoglobin, and then 10%, the rest of the story, is in the plasma. Of that 10%, we're going to zoom in more, we got only 5%, where we at here, is going to be our actual CO2, which our ABG machine picks up, all right, 4 to 5%. But the rest of it, the other 95% of the plasma that we're measuring, that whole 95% that we're getting on the chemistry, or the CMP or BMP, that is carbonic acid, right? When they add their reagent, all they're doing is checking how much bicarb you have. So this is a poor man's ABG. The serum CO2 on our BMP or CMP is actually your bicarb. It's exactly the same. It's only off by, I shouldn't say exactly, it's off by 4%. That's it, right? So it's a quick way, you know, if patient's on the floor and they then be upgraded to ICU, they probably have 3 days of labs. You can see that on the labs, the CO2 went from 24 to 20 to 18 to 12, and now they're in ICU. Why are they in ICU? Because the bicarb is A, being lost, or B, being utilized, right? It's being neutralized because it's binding to another acid. Why would it be lost? Because they have diarrhea or vomiting. They have diarrhea, right? So they have diarrhea. That could be a reason why, but I mean, you don't usually go to ICU for diarrhea. But usually it's it's one of the other things, the things that will kill you are the reasons why they come to ICU. Or was kill you again? They're building up what? K, ketones. I, they ingested some antifreeze, right? Family came over, got some antifreeze for you, right? Or they drank the alcohol sanitizer off the wall, all right? Someone gave, that can happen too. All right, so that will build up acids because they ingested things. L is what? The most common reason in the hospital setting, especially ICU, is lactic acidosis from an infection, right? So they started developing, the 85-year-old grandma started developing a pneumonia because of atelectasis, or she developed a UTI because she had a Foley catheter for 12 days, right? So these things are, you can see that the bicarb is dropping because of a buildup in lactate, which happens in sepsis, right? Or her blood pressure's been low, right? For the last 2 days, oh yeah, she runs low, you know, 80 over 40, 80 over 35, you know, maximum 57 to 62 per day, and lactate can start building up, right? Maybe they're going to heart failure, and that's what's happening. Okay, or U, another thing that happens in the hospital setting, and U stands for what? Uremia. Uremia is the buildup of BUN. BUN is not an acid. BUN is actually nonpolar. It'll go anywhere and cause confusion, like in the brain. But we were saying the reason why your BUN is going up is because you're likely going into renal failure. And in renal failure, you're not getting rid of hydrogen, and you're not getting rid of potassium. When your potassium goes up, your hydrogen also goes up, right? So they could be going into kidney failure. So we can look at the labs also on our chemistry. They'll kind of clue us in. Oh, look, they're going, it's perfectly correlating. My creatinine went from 0.5 to 1 to 2 to 3, and my bicarb went from 24 to 20 to 15 to 10. It correlates exactly. Okay, so it's a perfect way to figure out if someone is getting acidotic or not, right? So it's not equal to the serum, to the ABG or VBG CO2. It's equal to the bicarb, right? So even if you look at your little fold-up binders, right, that you got from nursing school, you might still use, right? It says on the back there, it says CO2/bicarb on your chemistry, right? Because it is the bicarb. They should just rename it altogether, right? Because it's very deceptive. It's always your bicarb. There's no factor where that would be your CO2. The only time you get a CO2 is if you do a VBG or ABG. Okay, so the reagents are testing whether you have the bicarb or not. Okay, and on your ABGs, when they give you a bicarb, it's estimating that bicarb. It uses this Henderson-Hasselbalch equation. If anybody makes you memorize that, it's useless, right? It's not going to do anything. Your ABG machine does that for you. Okay. There are ways to say if they are compensated or not, but it doesn't. You can kind of look at the clinical picture. You can look at the CO2 if they're compensated or not, right? Because your bicarb starts going down and down and down and down. What are they going to do to compensate? When you're really, really acidotic, what do you want to do? Do you want to hold on to carbonic acid, or do you want to get rid of carbonic acid? You want to get rid of it, right? So they're going to start breathing faster, right? You're going to start seeing the CO2 go down in the ABG as the bicarb goes down, right? That's how they compensate. So trends in the patient's BMP can tell you if they're getting more acidotic, right? It's like, I can't figure out where the blood pressure is low. It's like, well, let me look at the last couple of chemistries. All right, you look at the chemistry and the CO2 is, right, CO2, nope, let's cross that out. Bicarb is 8, and then now it's 5. Well, shoot, that is a sick patient, right? So otherwise, the labs look decent. The K is a little bit high, but why is the K high? Well, BUN and creatinine, I don't have the creatinine here, but the BUN doesn't change. So I got to think of other things. They could be getting infection, or maybe they're going to DK, all right? And you can trend that, and that's what we do trend on the DK. We look at the bicarb. If the bicarb is normal, how do we know it's normal? Because of the chemistry, right? And also we measure what's known as the anion gap, which tells us how many acids are present. Yes?
So then somebody like in renal failure that's vented and on a bicarb drip, is the intention at that point then to just utilize the respiratory rate to get rid of that acid?
So when they're in the bicarb drip for renal failure, that's used to just
that's
supplement the acidosis, right? Because usually when you're in renal failure, bicarb starts dropping, right? Usually it gets about 16 to 18. When it's less than that, it's usually something else also causing renal failure. But you're giving the bicarb to help optimize the proteins on the previous slide, right? You want your cells to work at the optimal capacity. It's renoprotective, basically. Just like how you give mucomist for someone with Tylenol overdose, it's like bicarb for renal failure.
But if we're just hiding the hydrogen ions at that point, then the intention is to get rid of them through.
You're neutralizing the hydrogen ions, yeah. So when you give bicarb drip, you are neutralizing the hydrogen ions to hopefully normalize it. And that's a good point, because when you are neutralizing the hydrogen ions, we can use the chemistry to see if they need the bicarb drip anymore. Sometimes they're on bicarb drip for 3 days and no one's checking the bicarb, right? Yeah, they could be doing ABGs, but the bicarb drip is supposed to be bringing up my bicarb. My bicarb is 28. It's like, well, we don't need bicarb drip anymore, right?